Welcome to this episode of the Referrology series. Today we are very privileged to have Dr. Lionel with us. He's an infectious diseases consultant, and he's also a very great teacher. So today we'll be talking about dengue. The reason why we chose this topic is because it's a very common condition that we actually see here in Singapore. At the same time also, we read in the news about how there's actually been quite a lot of mortality cases. So I think we've identified it as an important condition to discuss. So today we also have Dr. Carmen, who's an internal medicine resident, who will be asking the questions for today's discussion. So we'll start off with a case scenario.
Hi everyone. So for the case scenario, we have this lady, Alice, who is a 30-year-old lady with no past medical history, and she presented with a 2-day history of high fevers, headache, and myalgias. She also had generalized abdominal pain, nausea, and vomiting. So the dengue duo was done, and NS1 was positive, while IgM and IgG were negative. So this brings us to our introductory point, which is why is dengue an important condition to diagnose? Isn't it just another viral infection?
Yeah. Okay. So thanks for inviting me. So it's true that dengue is a very common mosquito-borne viral infection in Singapore. In fact, I think 40% of the world population are at risk. And last year in 2022, we had about if you read in the news, about 32,000 cases, second highest to 2020. And diagnosing dengue is really quite important at a patient level as well as a public health kind of level. So at a patient level, it's important to diagnose it because we do know that dengue has severe complications and may potentially be fatal if not thought about early, especially with our aging population with comorbids who are also known to have very atypical presentations. And at the community level, it is important to also diagnose dengue for epidemiological reasons and to assess the effectiveness of our vector control measures. Yeah.
Thank you, Dr. Lionel. So this brings us to the next discussion point, which is how do we diagnose dengue? We're wondering how we can go about interpreting the tests that are commonly done for dengue, whether there are any false positive or false negative results, and if the serologies were negative initially, but we still have a high clinical suspicion of dengue, is there any role of repeating the serologies? And lastly, whether there's any role of urine PCR as well as dengue RNA.
Okay, yeah, so this is a lot to cover. So I'll try to go through slowly with some charts. But clinically, diagnosis of dengue depends on a few of the common symptoms, and one of which, or a few of them, are fever, rash, myalgia, headaches, nausea, vomiting, together with leukopenia and thrombocytopenia. So that's highly suggestive of dengue in endemic area. So the diagnostic test is the dengue duo, which combines the dengue IgM and the IgG together with the non-structural protein 1. So that's called NS1. So in order to interpret the dengue duo, it is important to first know this, that in primary dengue, the NS1 is often present early on in the illness, followed by the IgM rising as early as about 4 days into the disease onset. The dengue IgG appears at a very low titer at about maybe 7 days of the disease onset and increases quite slowly. But in secondary dengue, you can see that there is a rapid rise in the IgG beginning about day 3 to 4 of illness. And what I want to point out here is that the sensitivity of NS1 in the primary dengue is much higher than that in secondary dengue. You can see that the sensitivity of the NS1 in primary dengue is about 90%, whereas it's about 60 to 80% in secondary dengue. So just be aware that NS1 may be falsely negative in secondary dengue. Okay? So how do we interpret such tests? I have here a table basically depicting the 3 components of the dengue duo. So NS1 positivity in an appropriate clinical context suggests primary dengue with the IgM rising later on after day 4 to 5. NS1 positivity together with IgG positivity, right, signifies secondary dengue, right? An isolated IgG, okay, would signify past dengue infection. So now the conundrum is always the last two, where you have isolated IgM positivity and IgM positive with IgG positive, right? So the isolated IgM may mean will mean that for recent, it may mean a recent dengue meaning that the IgM rises as early as day 4 to 5 of primary dengue infection before the IgG rises, or it could be a false positive IgM. So that occurs usually from cross-reactivity with other flaviviruses. We have reports also of, I think, COVID, where patients also had a false positive dengue serology. So in these cases, what is sometimes helpful is to confirm with a serum dengue PCR during the febrile or the viremic phase. Or alternatively, you can repeat the serology in about 2 weeks to watch for IgG seroconversion. Similarly, for those with IgM and IgG positive, it presents another diagnostic conundrum. So it may suggest someone with recovered recent dengue, or someone with past dengue with false positive IgM, or someone with secondary dengue. Again, dengue PCR may be helpful to confirm if a patient has secondary dengue. And the last thing I want to mention is false positive NS1, which occurs in less than 2% of the time. Reports suggesting concomitant CMV, other flaviviruses, and hematological malignancies such as lymphoma and AML are some of the reasons for false positive NS1. There was a question on repeating dengue serology initial negative tests. So if there's high clinical suspicion of dengue, then either a PCR or a repeated serology may help, particularly if IgM turns positive, especially after day 4 to 7 of illness. Then the question of a urine PCR. There is really no international recommendations for universal screening of urine dengue PCR in routine clinical practice, but there have been some reports of dengue transmission on organ donors found shedding with dengue urine PCR. So locally, I think in the transplant units, they have augmented the donor screening to screen organ donors urine dengue PCR. Does that help?
I see. Thank you so much, Dr. Lionel. I think that was really very helpful. So I think we have a better understanding of how to interpret the dengue serology currently. So moving on, it will be to re-stratify our patients with dengue, because as we know, dengue is on a spectrum, and patients can come in with varied clinical presentations, some more severe than others. So we were wondering also what kind of signs and symptoms should we look out for in terms of this risk stratification, and what investigations should we send out for, and how do we decide who can be managed as an inpatient setting versus outpatient? Okay.
All right. So basically, there have been a few classifications for dengue, and the latest one is WHO 2009 classification, which looks at classifying dengue into probable dengue, dengue with warning signs, and severe dengue. So I think this is what is widely used around the world now. And basically the symptoms as is what is written on in the first box, right? Nausea, vomiting, rashes, aches, pains, leukopenia. Okay, and anyone with warning signs would include someone with abdominal pain, tenderness, vomiting, fluid accumulation, mucosal bleeding, lethargy, restlessness, or even hepatomegaly, or a lab finding of an increase in hematocrit with a rapid decrease in platelet count. So how do we actually stratify dengue? If you have someone with any one of these, severe plasma leakage, severe hemorrhage, or severe organ involvement or impairment, then that's considered severe dengue. So I think in terms of history, you've really got to, and physical exam, you've really got to look out for the warning signs. That's really important, as well as signs of severe dengue. So in terms of plasma leakage, you're looking at more fluid accumulation, so pleural effusion, ascites, and so on and so forth. Bleeding is quite straightforward, but organ involvement can affect virtually any organ in your body. So you can have severe hepatitis, you can have encephalitis, or you can have even myocarditis, right? So in physical exam, really got to not really examine the entire body and have a systemic review, but also just to mention that you've got to look at the blood pressure very carefully and to measure a postural blood pressure, because if there's a postural drop, then of course that would tell you that intravascularly the patient may be depleted. There may be some plasma leakage already. What is dangerous is that if you see that the pulse pressure is actually narrowed to less than 20 millimeters per Hg. Okay? And then of course look out for the hydration, because a lot of times they have very poor oral intake, so hydration status is really important. In terms of investigations, besides the dengue duo, we do check the whole blood count regularly, sometimes more than once a day, depending on whether you are doing fluid resus. I'll go through that with fluid resus later. We do check the renal panel, particularly for patients who have poor oral intake, lethargy, vomiting, or unable to take food orally. And then LFTs, liver function. We don't usually check the liver function routinely unless the patient's got symptoms suggestive of transaminitis, so nausea, vomiting, or abdominal pain. So the question is, who do we admit from the emergency department, or who can we try to tide over in the outpatient setting? Really depends on the clinical status of the patient as well as the phase of illness. If the patient presents with a febrile phase and has no warning signs, I think it's quite reasonable to house the patient in outpatient setting. But if the patient does have any of the warning signs or any signs of severe dengue, plus the patient is in any of is included in the critical phase, then of course that would be an impetus to admit the patient. Okay. Then of course, if the patient had fluid resus and there's still persistent postural drop or narrow pulse pressure, or the patient is unable to take orally, then of course admit the patient. So these are the few things we look out for before we decide to admit the patient.
Okay, thank you, Dr. Lionel. So going back to our case scenario, I think we would admit this patient because she presented with dengue with some warning signs such as abdominal pain, nausea, and vomiting as well. So actually, in terms of her vitals, she has a borderline low blood pressure, about 90/55. The postural blood pressure was not recorded in this case. In terms of her lab tests, mainly we can see thrombocytopenia and transaminitis as well. So going on to after diagnosis and re-stratification, I think we were wondering also about how much fluid should we give the patients, and also how do we determine how much, what kind of fluids to give, and whether there's any role for platelet transfusion in thrombocytopenia. And what kind of complications do we look out for? And moving on from admission, once they're admitted, what is the threshold to admit to high D or even ICU?
Okay, so not all dengue patients. I think I have to first start off saying that not all dengue patients need IV hydration, contrary to what is commonly practiced. We did publish dengue fever guidelines on the intranet under the Department of Medicine. So you can take a look at that. It's actually adapted from the WHO as well as the Tantoxin guidelines. So maybe let me just go back to that scenario to say that looking at the blood pressure, that's quite worrying, right? Because it's low. I'm assuming that her usual blood pressure is higher than that. But what's lacking here is also the hematocrit from her full blood count, because I'm not too worried about the platelets. Usually it's the hematocrit that would tell me or prognosticate more than the platelet count. Because if you have hematocrit that is rising, then obviously you'll be thinking more about more plasma leakage and intravascular depletion. And that is something that I would be worried about. Okay. So let me just go through who I would consider IV fluids for. And the reason why we are being so judicious about fluid resuscitation is because we want to avoid fluid overload, especially when the patient recovers and gets out of the critical phase into the recovery phase, that's when a resorption of fluid occurs. So sometimes if you are too aggressive in your fluid infusions, then they may get fluid overload in the later stages. But we would actually consider IV fluids if the patient is hemoconcentrated or the hematocrit is 20% above the baseline, or the patient is unable to take orally, or the patient is in compensated shock, meaning that the blood pressure still sustains above 90 systolic, but has a narrow pulse pressure. Okay, so these are people you want to consider for high dependency and ICU. Or, of course, if the patient is in hypotensive shock, then that person has to be in the ICU. Yeah. So there are various algorithms in which we can refer to for fluid management in compensated shock and in frank shock. But in general, this is the schema for compensated shock, meaning that the patient has a narrow pulse pressure. So it depends really on whether the patient has comorbidities or not. But generally, we use normal saline or Hartmann's. And we can give 500 mils in 1 hour if the patient is well, or if the patient has some degree of comorbidities, renal impairment or cardiac involvements, then 250 mils in 1 hour. What I have to emphasize is that after you give the fluid challenge, you have got to repeat the full blood count, the hematocrit, because it's kind of like how we do fluid resuscitation in septic patients when we measure their lactate after fluid resus. So for dengue, we actually use hematocrit as a surrogate of how effective our fluid resus is. So if there's improvement in the hematocrit, then we follow this algorithm here, and you can actually refer from the intranet guidelines, 250 mils in 1 hour, and then you cut down to 500 mils in 4 hours. After that, you repeat the hematocrit and you sustain them with a maintenance strip of 500 mils in 8 hours. So again, I emphasize that we are trying to be judicious in terms of the amount of fluid that goes into the dengue patient, because we don't want to risk having fluid overload in the later stages. However, if the patient is not responding, meaning that the hematocrit doesn't come down or it keeps rising, then again, we give 500 mils in 1 hour. If there's no improvement, okay, then please really escalate the entire process to your registrar or consultant, because that's quite worrying about that the patient is progressing to dengue shock. Okay? The other thing that I've got to mention is that the hematocrit drops precipitously, then one thing to remember, if the patient turns hypotensive, is really bleeding, whether the patient's got hemorrhage. So be very careful. If you see a very, very sharp drop in the hematocrit, then please remember to at least do a DRE and exclude signs of bleeding. In a patient with hypotensive shock, meaning that the blood pressure is below 90 systolic, that in this case, you really don't have much of a choice. You really have to give 500 mils of Hartmann's or normal saline fast. And if not improved, give another 500 mils fast, so a total of 1 liter. And then you repeat the hematocrit. Again, if there's improvement, go down this pathway, which will guide you to 500 mils in 8 hours maintenance drip. If there is no improvement in the hematocrit, then again, you do 1 liter in 1 hour, right? Measure the hematocrit again, and then go through this algorithm until the patient improves. If the patient doesn't improve, again, look out for the hematocrit. Again, if it's decreasing very, very precipitously, then of course, that would mean that you've got to look out for bleeding.
We wanted to ask whether there's any role for platelet transfusion in dengue, since there's usually thrombocytopenia, and if there's any clinical signs of bleeding, would that prompt us to transfuse the patient?
Yeah, so for dengue, we do see time and again patients with platelets that drop below 20. And there was a trial conducted. It's called ADAPT trial, where they randomize patients to receive platelet transfusion when their platelets dropped less than 20, I think, versus no platelet transfusion. And there was really no significant difference in both groups. But with platelet transfusions, there were actually more side effects, things like anaphylaxis and blood transfusion reactions and the works. So in general, when we talk about prophylactic platelet transfusions in dengue without clinical bleeding, that's not advocated for dengue. But if you're talking about someone who is actively bleeding, say a GI bleed or some mucosal bleeding, then yes, please go ahead with the platelet transfusion.
Thank
I
you,
hope that's
Dr.
clear
Lionel.
now. Yeah.
Yeah, that was very helpful. So moving on from then, I think you have mentioned some of these points as well. We wanted to just clarify about like these markers to look out for as well, like the fever and platelets, as well as transaminitis. Because from our understanding, defervescence, meaning lysing of the fever, does it point more towards moving on to another phase of the dengue illness?
Yes. Yeah.
And as well as for the platelets, do all patients with dengue have thrombocytopenia? And is there an anticipated trend, like when it starts to drop or start to rise? Is there something that we have to watch out for?
Yeah.
As well as lastly, transaminitis. I think you have mentioned earlier that not all patients will need LFT check unless there are clinical signs and symptoms suggestive of it.
Yeah. So certainly for fever, when the fever lyses, that's when the patient progresses from febrile phase into the critical phase. It's not really prognostication, but it just informs us about the transition to the critical phase. But when the fever lyses, I think the next thing that would happen is that the platelets start dropping further. In fact, it won't recover within the next 1 day. So you expect, or you can tell the patients that once the fever lyses, you'll be expected to have a platelet drop for 1 more day, 1 or 2 more days. In terms of the platelets, do all patients with dengue have thrombocytopenia? I think majority would have some degree of thrombocytopenia together with leukopenia. 80 to 90% of the time, the platelets will drop below 100,000, while 10 to 20% of the time, you'll see critically low levels of platelets like 20,000 or less. And we do notice in terms of trend that the WBC trend, the white cell trend, tends to rise in the recovery phase about 1 or 2 days before the platelets recover. So if you really want to know whether the platelets or the patient's really recovering, then look at the white cells first, because usually the white cells will come up before the platelets. Yeah. What will be worrying is if we see a sharp drop in the platelet count with a very increase in the hematocrit, especially more than 20% of the baseline, or if the hematocrit is more than 50%, then that's something that you want to call as alarm bells, because that might suggest ongoing plasma leakage. However, a sharp drop in hematocrit is in someone who's hypertensive, mentioned earlier, raises the concerns of bleeding. In terms of transaminitis, should all patients have LFTs checked? Not everyone, except if they are symptomatic or if they are in severe dengue. So sometimes severe dengue, you look at the third component, it's really organ impairment, and sometimes you will see transaminitis going to the range of thousands. Okay. In a patient who had already an LFT checked, when should you recheck? Usually about 2 to 4 weeks after recovery would be fine to ensure normalization.
Okay, thank you. Going back to our case scenario, for this patient, fever lies about day 6 of illness, her symptoms improve and she's taking well orally. However, her platelet count is about 35 with slight improvement from 20 the day before. So our next question would be, a discussion point would be, when would it be safe, considered safe to discharge a patient with dengue, and how do we follow them outpatient?
Yeah. So her fever lies, she's resolved, she's eating well, her platelets counts going up. Definitely for this patient would be able to send home. So the criteria for discharge really depends on 3 components, where the clinical status of the patient-related factors, as well as the phase of illness. Let's go by the phase of illness first. I seldom discharge a patient who is just entering critical phase, because I think that's the time where it's the danger period. So that's quite self-explanatory. However, I have discharged febrile patients to our dengue outpatient management clinic when they have no signs, no warning signs, no severe dengue, and they are very compliant and they're educated patients. And in terms of their clinical status, they are hemodynamically stable, hematocrit has no red flag signs, and they are able to take well already. So I think don't be limited by the phase of illness. You can still discharge the patient in the febrile phase if the patient has very good clinical status and is a very compliant patient. But once the patient has some warning sign or has a postural drop that is not getting better, or narrow pulse pressure, or is entering a critical phase, then those are the ones that I tend not to discharge so early. Yeah.
I see. Thank you, Dr. Lionel. So after they have been discharged from hospital, I see that for some of them, they do get checks like in outpatient OPS in about 2 weeks' time to make sure that their platelets are on an upward trend. Do we routinely do that? And for which patients do we send to the ID clinic, and which can we send to the OPS clinic?
Yeah. So I think in general, we will recommend that they would get a full blood count maybe a week after their recovery, or a week after they get discharged from the wards. It can be with the GPs or with the polyclinics. The other option is the dengue outpatient management clinic, where it's situated at level 3 medical center. It's run by the ID physicians, and it opens about 7 days a week, half days on weekends. The patients that we would usually take to the dorm clinic are maybe the ones who are a bit more frail, and the ones who perhaps maybe you have discharged during the febrile phase and would like to watch over the critical phase. So the dengue outpatient management clinic can do that. But of course, do not discharge patients who are unstable, right? So we only accept stable dengue patients. Or patients who have recovered, but perhaps you are a little bit worried because the platelet recovery is a little bit slow, then you can put it to dorm clinic, and you can monitor the patient in the dorm clinic with daily FBCs and hemodynamics, or even every other day, till they're stable before handing them back to the OPS.
Okay, thank you, Dr. Lionel. I think finally, to wrap up, we have 2 final questions. Firstly, we see sometimes patients being labeled with secondary dengue, and we're wondering if there's what is the significance of labeling them as primary or secondary, whether it changes management. And secondly, whether there's any role for dengue vaccination, because I understand it's recently been rolled out.
Basically, for the management of primary and secondary dengue is going to be the same. The worry with secondary dengue is that we do see more severe dengues with repeated dengue infections, and that's postulated to be due to those immune enhancement type phenomenon. The immune enhancement phenomenon is a postulation of the binding of the virus to non-neutralizing antibodies from the primary infection, and then that enhances its entry into host cells and followed by its replication. So people have seen more severe dengues with repeated dengue infections. But I would say that the management is going to be very, very similar to primary dengue. In terms of the role for dengue vaccination, the vaccine that we have here is Dengvaxia. It's a commercially available one in Singapore. It's a live vaccine. Unfortunately, the efficacy is not the best. For DEN 1 and 2 serotypes, it's about 40 to 50% maybe effective. And then 3 to 4 is about 70% effective in decreasing hospitalization for severe dengue and mortality. The large clinical trials have found that those who never had dengue before are at higher risk of getting severe dengue if they receive the vaccination. So it is for this reason why WHO recommends vaccination programs only for highly endemic areas where at least 80% of their population had dengue before. In the case of Singapore, where the population has not reached this threshold, then its use is recommended only to those who have evidence of past dengue or serological evidence of previous dengue. and restricted to those 12 to 45 years of age. It is usually, it's good to always have the serology to show that the IgG has been positive before you give the dengue vaccine. And it's, I think, a 3-dose vaccine at 0, 6, and 12 months.
I see. Thank you, Dr. Lionel. I think this
Yeah.
brings us to the end of our referrology series on dengue fever. It's been a very helpful session. Thank you.
Yeah, thank you.